Is it because of the linear reception? Or? Oh, okay.
Yeah, really, yeah. They want us to be on.
Right. Which and then people come in or not? Yeah, they don't know. was covered last time. They don't understand the concept. You know, it's like the same.
we on the side here.
Yeah.
Here.
Anything you advise what's going on?
There we are. So that's camera is right. So we are here. All the people will be here. They will be straight. And the speaker is on. The speaker is on.
This thing is come up, so anybody sits down.
jet lag. Look at the travel. Yeah. Aku pakai dah kan dia. Aku kan.
陈医师来了，陈医师来了。
There's a group. It's all right. We're in a forum. That's all right.
Yeah, I would open that.
We're in a forum. Come on, bring the thing. Yeah, this one.
Somewhere.
Yeah.
There's a group in kids home. And there's a group in the field.
They're watching from there.
Come over here. Where yesterday pastors come over here yesterday. You know, she doesn't know where. Who's in there? Who's in there? I didn't check. I need to go back. Check there. Don't say anything, just check down there.
I have no idea, maybe. But I don't. It must be. So.
We have no question. We don't know.
Is it screen mostly? This is English, maybe short.
一路镜头跟麦克风都是开的。
Yeah. Could everyone test?
Hello.
But how do I want to just listen.
Oh, okay. OK. 庭长听得到我的声音吗
？Yes, perfect.
OK, perfect. 那我就先静音了。
好。Okay. So the seminar will be going to start in 1 minute. Yeah, so everyone should be ready, right? Good. Yeah, good to see many of our friends from the Moresby General Hospital, I think. Yeah, that's good.小俊浩，他的那个如果你们还在弄的话，萤幕先关掉。那个。Okay, good. So, okay, we are going to start our online seminar. Thank you very much for all of our distinguished guests from Taiwan, from Papua New Guinea. So good morning and good afternoon, ladies and gentlemen. Thanks to join today's online seminar. I'm Lina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. I'm also the moderator of today's seminar. So first of all, I would like to thank our distinguished guest participants from Papua New Guinea, from Taiwan, and of course, our two ambassadors and our four speakers, Dr. Xie, Dr. Chen, Dr. Richard, and Dr. Elizabeth. So before we start our seminar, I would like to invite our distinguished guests to give the remarks. The first, I want to invite the representative of Papua New Guinea Trade Office in Taiwan, Mr. Tommy, to give the remarks. Tommy, please.
Thank you. Thank you, Dr. Nina. Good morning, Taiwan, and good day, Papua New Guinea. I'm Tommy Kunji, the representative at the Papua New Guinea Trade Office here in Taiwan. Let me firstly acknowledge the distinguished participants. Dr. Nina Gao, CEO of the Overseas Medical Mission Changhua Christian Hospital, and the moderator of this online seminar. Ambassador Oliver Liao, the Taipei Economic and Cultural Office in Papua New Guinea, Councillor Ling Liu, Director Office of International Cooperation, Ministry of Health and Welfare, Taiwan, and our esteemed speakers, Dr. Xi Chen-Fu, Dr. Chen Ying Chen, Dr. Richard Kanawi Kulau, and Dr. Elizabeth Alok. Distinguished online participants, guests, welcome online. Firstly, let me thank Changhua Christian Hospital and Port Moresby General Hospital. Another webinar to share experiences on orthopedic and cardiovascular surgery in Papua New Guinea and Taiwan. I would like to also acknowledge and appreciation and the Foreign Affairs of Taiwan for supporting this online seminar and also the previous ones as well. This seminar actually coincides with the completion of training for Drs. Kulau and Alok under the recently signed MOU between the University of Papua New Guinea School of Medicine and Health Sciences and the Changhua Christian Hospital. Therefore, let me acknowledge Dr. Damien Joseph Asola. I don't know whether he's online or not, but for initiating the discussions. And thank you to Drs. Nakafi Teporani, Dr. John Vince, Dr. Ikao Kebao, and Dr. Tipoki for signing this MOU with Changhua Christian Hospital. It's a step in the right direction and a correct deviation from the Waigani bureaucratic swamp where things are getting stuck and not moving. Dr. Kulau and Alok will share their experiences on orthopedic and cardiovascular surgery in Papua New Guinea and what they have learned in Taiwan during their training. We hope that their training and experiences will enlighten other Papua New Guinean doctors of what Taiwan can offer in terms of training and experiences towards their specialized training. And we look forward to having more Papua New Guinean doctors come to Changhua for training in the future under the MOU. Though through the seminar, the presentations by our four esteemed speakers, we can learn of experiences and challenges of orthopedic and cardiovascular surgery in Taiwan and Papua New Guinea. I wish this seminar be successful and enable further collaboration and exchanges between Taiwan and Papua New Guinea, and more specifically, Port Moresby General Hospital, University of Papua New Guinea School of Medicine and Health Sciences, and Changhua Christian Hospital. Thank you.
Thank you very much for Representative Tommy to give us the remarks and also to present what is the orientation, why we have this program and we signed the MOU. So we also hope that in the future, more of the doctors from Moresby General Hospital can come to Changhua Christian Hospital to take the specialty training. So the next, I want to invite Councillor Liu on behalf of the Ministry of Health to say a few words for us. Dr. Liu, 季间有在线上吗？
有 yeah.
Oh, okay, please. Thank you.
Okay, thank you. Yeah. Representative Tommy Kanji, Ambassador Oliver Liao, Dr. Nina Kao, Dr. Chen, Dr. Xie, distinguished guests from Papua New Guinea and Taiwan. Ladies and gentlemen, good morning. It's my great pleasure to attend the Taiwan and Papua New Guinea online seminar on orthopedics and cardiovascular surgery and welcome all of you to this event. I also would like to take this opportunity to wish you and your loved one good health in this pandemic era. PNG is one of Taiwan's crucial allies in the South Pacific region. Over a decade, the Ministry of Health and Welfare has worked with the Ministry of Foreign Affairs to conduct the PNG medical program. Changhua Christian Hospital has been working on this project, including mobile medical services, medical staff training, equipment donation, international patient referrals, etc. During the pandemic, Changhua Christian Hospital not only transformed the on-site clinical training, but received Dr. Richard and Dr. Elizabeth from Port Moresby General Hospital to take specialty training for 3 months at the also
We lose the Councillor Liu. So I think there should be some of the internet problem. Oh, okay, go ahead. That's good.
I come back. Sorry about it. There's some IT problem.
We'll come back.
Okay. Today we are going to witness both doctors' training outcomes. I hope both doctors will apply the professional knowledge they learned at the Changhua Christian Hospital in their daily work back to Papua New Guinea. Lastly, I would like to take this opportunity to appreciate the Changhua Christian Hospital's continuous support and the contribution to building the relationship between Taiwan and the Papua New Guinea. Finally, wish you a successful online conference. I hope you enjoy it and may you have a good day. Thank you very much.
Thank you, Councillor Liu. And we also thank you very much for Ministry of Health and Welfare to support our program for over 10 years. So during the 10 years, they give us big hand to support this program and also to support our medical personnel training from Papua New Guinea. Thank you so much. So next, I would like to welcome Representative Oliver Liao from Taipei Economic and Cultural Office in Papua New Guinea to give the remarks. Dashi, please.
Okay, good morning, everyone from Taiwan and PNG. My name is Oliver Liao. I'm Taiwan's representative to PNG. It's a real pleasure for me to participate in today's online seminar focusing on orthopedic and cardiovascular surgery. I'm really happy that I'm able to physically join all these participants in Taiwan because I'm currently taking an annual leave back in Taiwan. And I also would like to thank the Changhua Christian Hospital and Peng Jian for organizing this seminar. And I hope all the participants will be able to benefit from today's discussion. And I also would like to acknowledge Changhua Christian Hospital for its long-term dedication in promoting exchange programs with its counterparts in PNG, including Port Moresby General Hospital and Nonga Hospital. Also, I take great pleasure in seeing the progress that Changhua Christian Hospital managed to make during the past a couple of years, especially when we're facing the hardship imposed by the current COVID-19 pandemic. I am aware that Changhua Christian Hospital, although they currently no longer send mobile medical teams to Port Moresby, but they still managed to sign the MOUs with Hongjam and also the medical school of UPNG. And I would really like to applaud such magnificent progress made by Changhua Christian Hospital. In closing, I wish today's seminar a great success, and I look forward to more similar programs in the future, as these programs surely will help to improve the medical care in both Taiwan and Port Moresby. Thank you.
Thank you, Ambassador Liao. So before we start our seminar, I want to invite our online participants to turn on your camera. We are going to take group photo, so everyone can turn on your camera and look at the camera. Say cheese. 1, 2, 3. Cheese. Beautiful. Cheese. Could everyone thumbs up? Yay, great. 1, 2, 3. Thank you so much. Great. Okay. I remember in the end of April, Dr. Richard and Dr. Elizabeth fly to Changhua Christian Hospital for their 3 months specialty training, and time is flying. They are going to finish their learning courses and back to Papua New Guinea very soon. So today we are going to witness their learning outcomes. So we have a short video to record their learning journey. I think the 2 docs, you never saw the video before. We will show this today. The short video will record their learning journey. So let's watch the video first. And I hope both of you enjoy your stay in Changhua Christian Hospital. Okay, you want me to share or 自然你可以 share？ 没有声音。啊 ？Okay. I will share. Let me share with you. Yes. And 放哪去？电呢？怎么不见了？没有啊。那边。等一下。你们看一下，有看到吗？ Congratulations to graduate. Okay. So, okay, now we're going to move to our seminar. So the first speaker is from Changhua Christian Hospital, Dr. Xie. He's the director of orthopedic departments. Dr. Richard follows Dr. Xie for the most of his training period. Dr. Xie will share the topic, limited getting along, limitless friendship. So Dr. Xie, you have 20 minutes to do the presentation. Now the floor is yours. Dr. Xie, please.
Thank you. I will present the course about 3 months with Dr. Richard from Papua New Guinea, and we take the information in the beginning of the 2022 about we will have the visitor doctor from Papua New Guinea. Believe me, it is not so familiar nature to most people in our country, but I know it. So we are very great to have the opportunity to communicate with the Dr. Richard from Papua New Guinea to talk about the experience and share the difference about the patient treatment and operation about orthopedic surgeon. The physical course is beginning from the 2022 May. We have morning meeting every morning in our department. So I invite Dr. Richard to attend our everyday morning meeting. He is always the first one arrived the meeting room. So I'm sure he is very serious about the training course. From the morning meeting, we built the beginning relationship with Dr. Richard and make a communication with Dr. Richard. We also communicated in the outpatient clinical. We talk about the difference of a patient who meant problems and the trauma situation in our country. Because my subspecial division is a sport medicine, so we also talk about the athlete trauma and special treatment for the athlete training. Except the outpatient diagnosis and the physical examination, operation experience is the key point to share for Dr. Richard. So we let the Dr. Richard have the operator experience about the arthroscope. In recent period, the arthroscope have advanced development. So the arthroscope is not only for diagnosis, but also for treatment and can do many procedures. We show the arthroscope surgery to the Dr. Richard, which the surgery can do many procedures and can repair or reconstruction of ligament and the soft tissue. We also show the shoulder arthroscope experience for Dr. Richard. The shoulder is the site spot injury often occurred. Now we can do many precise repair procedure or reconstruction procedure by arthroscope to treatment the injury. The open operation can do it before. This is also the shoulder arthroscope procedure, and it can do many repair procedure more precise and little wounds. As I know, the joint replacement is also the key surgery Dr. Richard want to see. So we have several joint replacement surgery can show to Dr. Richard and let Dr. Richard have the chance to experience the real operator and in the procedure we talk about the operation skill and what should do and what not should do. As I know, some implant to treatment community fracture or serious injury is not available in Richard's country. So we talk about the issue about how to adjust the implant. We show the previous operation experience by the chance we give the suggestion to adjust and use present implant in Richard's hospital. We can also reduce the cost of the operation from thousands of dollars to hundreds of dollars. This also the adjust the method to treatment same trauma. And my another subspecial division is a hyperbaric oxygen. So we also show the Dr. Richard the hyperbaric chamber and how to treatment the hyperbaric oxygen, the patient who need hyperbaric oxygen. We talk about the indication and treatment experience. As I know, the Papua New Guinea is also an island country like Taiwan. So there are many visitors to your country, and some diving injury will occur after the diving visitor. So we suggest Dr. Richard can produce the treatment chamber in here in his country in future. We also let Dr. Richard experience the treatment of hyperbaric oxygen to feel the pressure in the treatment period. I believe Dr. Richard will enjoy it. Dr. Richard also told to me he want to the treatment some children with the foot deformity like this club foot is popular in his country. So but there is no suitable brace or correct method to correct this deformity. So I'm happy I am behalf of our department of orthopedic. We will send one set like this Dennis Brown bar to Dr. Richard, and Dr. Richard can carry the set to his hospital and help the patient of children. Okay, our hospital is Dr. Lambert built in the 1896. He carried the love of God to Changhua. Like our president of a hospital, Professor Chen, often remind us we should share the love and the care to the people and the patient who need it. Like the first book, John, in the Bible, the fourth chapter and the 11th section. My loved ones, if God had such love for us, it is right for us to share love for one another. Thank you very much.
Thank you for Dr. Xie. I think that during Richard in the hospital, Dr. Xie take care of Richard, not only in the professional knowledge sharing, also his daily life. Like share you the rice dumpling when our holiday. So I think that it's a very good friendship in the future, and also not only for the training. Under our budget, we also will donate some of the equipment to to Richard and to Elizabeth to continue on their learning in Changhua Christian Hospital, and they can apply to their hospital. Okay, so the next speaker will be Dr. Richard from Port Moresby General Hospital, and he is going to share the overview of orthopedic in Papua New Guinea, the challenges of improving the orthopedic condition at the hospital. So Richard, you also have 20 minutes. The floor is yours, please. Go ahead.
Thank you, Dr. Shi.
Maybe you have to speak a little bit louder. We cannot hear you. Yeah.
Greetings, friends. Thank you for this opportunity. Now, I've been tasked to give a talk, which I'm much obliged to. My time is only 20 minutes, so I shall only give you a glimpse of what practice is like for an aspiring orthopedic trainee in a developing country. So that's where I come from. It's roughly 4,400 kilometers apart. In terms of land size, PNG is 13 times larger than Taiwan. I guess that's the only thing we're larger than Taiwan for. To even talk about orthopedics in my country, let me highlight some background details to help put things in perspective. We have an approximate population of 10 million people. The GDP of Papua New Guinea is $26.6 billion, which is 26 times smaller than that of Taiwan's, which is roughly about $700 billion. 85% of our workforce is in agriculture. Our main industries are in extraction of gold, copper, oil, and gas. We also have agriculture, fishing, and export of cash crops. We export to Australia, China, Japan, and Taiwan. Our healthcare services in Papua New Guinea are inadequate and are almost exclusively funded by government. This basically means that they give us what they think is appropriate and you make it work. So if you fall short before the next funding arrives, you go into life support mode. There are very few functioning hospitals, and the current healthcare infrastructure is a combination of government, private facilities, and church facilities. Most of the healthcare facilities are in urban areas. Now, the birth of orthopedic surgery in Papua New Guinea began in 1995 with the onset of the university program in orthopedics. In 1998, Professor Ikau Kevau and fellow orthopedic surgeon Dr. Toki and Nina became the pioneers in the field of orthopedic surgery. Currently, if my memory serves me right, there are 10 orthopedic surgeons local in the country, 7 of which are locals. It includes Professor Ikau Kevau, who's a full-time teaching professor now. We have 1 retired orthopedic surgeon. We have 1 orthopedic surgeon in the military, and we have 4 remaining working public sector orthopedic surgeons. Now, these surgeons all attained their qualifications from the University of Papua New Guinea after various international overseas attachments in countries such as UK, Australia, Singapore, and New Zealand. Now, we also have 3 expatriate orthopedic surgeons, one of which was trained in Papua New Guinea and is now a teaching professor at the 2nd Medical School of Papua New Guinea. We also have a Polish, an orthopedic surgeon from Poland, who is also a priest, who works full-time at the public hospital. And recently I've come to learn that there is an Indian orthopedic surgeon who practices at the largest private facility in the country, which is located in Port Moresby. At our hospital, at Port Moresby General Hospital now, we only have 1 practicing orthopedic surgeon, Dr. Asa, after our other orthopedic surgeon was transferred to another hospital also within Port Moresby. Now, so how long does it take to get from medical school to an orthopedic surgeon? You spend 5 years in medical school, followed by 2 years in pre-registration using a provisional license. Then you also followed by 2 years of services to state as a licensed medical practitioner. Now, 4 years of general surgery training follows, followed by 2 years of service as a general surgeon, and finally getting to do another 4 years of orthopedic training to actually become a qualified orthopedic surgeon. It takes a minimum of 19 years to get from freshman to an orthopedic surgeon. However, there is an advantage. The advantage of this program is that all orthopedic surgeons in my country are general surgeons. So if you're not practicing orthopedic surgery, you can still utilize your general surgical skills to serve where needed. For the hospital I work in, Port Moresby General Hospital, is the national specialist referral and teaching hospital of the country. We have 2 orthopedic units, which combined, we have a total of 54 orthopedic bed ward. That's usually 79% occupied on any day on average. In 2021, we totaled 1,191 admissions. Our total outpatient clinic recorded 2,638 attendances last year. For the admissions to the ward, the average length of hospital stay is 7 days. We conducted a total of 914 operations in 2021 with a cancellation rate of 25%. Our perioperative mortality rate is 0.3%. Now, the challenges that I encounter usually in my hospital. One notable area of concern in our setting are the conditions surrounding the hip region. And this is a common challenge for any orthopedic trainee. Fractures surrounding the acetabulum, femoral head fractures, neck of femur fractures, osteonecrosis of femoral head, intertrochanteric fractures, and subtrochanteric fractures are all fractures that we encounter daily. Neck of femur fractures in our hospital are usually very unwelcoming diagnoses because safe surgical options for me are limited, usually by the non-availability of essential equipment, instruments, and consumables. However, DHS and cannulator screws have been done, but quite infrequently. Shoulder pathologies is another concern of ours. Shoulder pathology in our hospital are rarely admitted to a hospital, and it's not because they don't care, but more so because we are limited again by our interventional options. And the lack of arthroscopic equipment has been one of the more notable factors. Knee joint injuries, usually related to sporting injuries, are managed usually using conservative means. We share this responsibility with the physiotherapy department for management of these conditions. These procedures were once performed routinely in the days when Professor Ikao Keva was actively operating. Over the years, the dwindling support has trickled down to non-existent levels. Arthroscopic repairs would be our best option for management of such injuries. In terms of spinal surgery, in our practice, we are limited to emergency decompression of paravertebral collections via costotransversectomy surgery. This is done usually without augmentation or instrumentation, but it's the best we can offer with our limited resources. My Taiwan experience and observation, my stay in Taiwan and in particular Changhua Christian Hospital has opened new possibilities for me. I have observed more surgical skills to help build my arsenal of operating capabilities. Some necessities I have seen in acetabular fracture management are usually the available wide array of implants they use, the instruments that they have in their possession. And notably, a C-arm is very much an essential equipment to have in your practice. And obviously, more practice will give us better outcomes. For femoral head fractures, I didn't really get much of femoral head while here, but neck fractures, I was privileged to observe some of the new neck of femur systems that they use here. especially with the advantage of one of the anti-rotation screw that provides rotational stability. And then there's that bolt that maintains the reduction, followed by the plate that actually provides angular stability with 1 or 2 holes being locked in with 5mm locking screws. This system actually provides 100% more resistance to varus collapse as seen with previous systems of management of neck or femur fractures. For avascular necrosis or osteonecrosis of the femoral head, here in Taiwan, first choice of treatment is hemi, arthroplasty. I've seen a fair few of them during my stay, quite privileged. I've also had the privilege of observing almost all forms of arthroplasty there is. Furthermore, I've also seen complications that are related to arthroplastic surgery. At least I am aware of the kind of possible complications, and I've been around to see how most of those complications were managed. And I'm quite thankful for that. The indications for arthroplasty here usually are of non-inflammatory degenerative conditions, including osteoarthritis and avascular necrosis, rheumatoid arthritis, correction of functional deformities, revision procedures where other treatment or devices have failed, and non-unions of femoral necks and trochanteric fractures of the proximal femur, also with head involvement that are unmanageable using other techniques. Those are conditions in which they employ the use of arthroplasty. Arthroscopic procedures. Arthroscopy can be a very useful diagnostic tool as well when dealing with joint pathology. For the knee, I was privileged to be with the Chief of Orthopedics, Director Shea, who was very kind enough to show me my first knee arthroscopy procedure. ACLs were either artificial or by autograft, usually a 2-bundle procedure. Autograft repair was done utilizing the hamstring. I've always heard about it, never got to see one, and I was quite happy that I was part of the team that got to do such procedures while here. And once or twice we had to use the peroneus longus tendon for augmentation. I only got to see one PCL repair, but it was a very satisfying operation to watch. And I was also given enough opportunity to perform general examinations using the arthroscope and assisted with ACL repairs. Meniscal repairs were quite numerous. Shoulder surgery. I was shown arthroscopic procedures of the glenohumeral joint as well. Dr. Shi gave me opportunity to have a feel of the shoulder arthroscopy. He is an expert at the shoulder, and I appreciated his teaching during his operation. I also observed surgery for impingement, shoulder impingement, massive rotator cuff tears, slap lesions, Bankart lesions, frozen shoulders, and even ruptured long head of biceps tendon with the Popeye arm. And there are some basic things we need if we're going to embark on starting this service. First of all, to get an arthroscope, good irrigation systems, good consumables, and of course, lots of practice. In terms of spine surgery, I had the opportunity to observe some simple procedures that we may think about adopting easily. I saw them use the Wallant technique. Wallant is basically wide awake local anesthesia with no tourniquet. In this procedure, they use a combination of local anesthetic and epinephrine to induce anesthesia and hemostasis in the area of the surgical procedure. And the practice is the use of balloon kyphoplasty for reduction and bone cement introduction for stabilization of the vertebral compression fractures. And to my surprise, these cases are day cases. This patient gets to walk home on the same day. For the more complex spine procedures, such as seen in lumbar spine spondylosis, a combination of decompression, bone cage insertion, and instrumentation is applied. And this can be by minimal invasive means or mini-open, microscopic, or even endoscopic means. All these methods are available here at CCH, and I've seen a few of them. So my CCH experience at Changhua included, rightfully as mentioned by Director Xie, included operations, whether I was just an observer or I participated in the procedures. Also attending clinics, usually, but not exclusively, with Dr. Xie, Dr. Shan, and Professor Wang, who is the only orthopedic professor here. Ward rounds were usually with Dr. Xie. Clinical academic meetings are almost every morning, as mentioned by Dr. Xie, and it's 7:30 on the dot. Fridays are usually at the combined hospital grand rounds, which I have attended almost all of them. Other meetings which I attended were hyperbaric oxygen therapy meetings, and there were usual occasional religious Christian worship meetings, webinars that were organized by CCH, Overseas Medical Mission, and also workshops that were also organized, of which I will be attending one tomorrow. How has this experience helped me? This attachment at CCH has given me more than just a clinical experience. It has given me new ways of looking at improving in areas of efficiency, effective resource utilization, financial accountability, patient satisfaction, and also learning along the way accreditation of a division. My thoughts for the future. For arthroplasty, I believe is a very real possibility for Port Moresby General Hospital. We could start with bipolar, hemiarthroplasty, and then gradually move on to total hip, total knee, and hemi knee. Nothing hard about it. Arthroscopy services may take otherwise a little longer, from my personal opinion, basically because of the logistics and instrumentation and supply chain that's usually associated with it, and the learning curve may be a little bit longer. Spinal surgery, on the other hand, I don't think is very difficult. We can do this within a year. A C-arm would be a key start to getting these procedures going, starting with kyphoplasty, vertebroplasty. I mean, they could do them in a day here, a day case. We could do this also. Hyperbaric oxygen therapy, I think, will become a very important modality in the near future. As Port Moresby General Hospital embarks on going into radiotherapy, we will be encountering radiotherapy complications. Some of these radiotherapy complications are only curable by hyperbaric oxygen therapy. Now, how can we do this? Arthroplasty, arthroscopy, spine. What do I mean by how can we do this? We need to talk to people. We need to talk to companies. We need to talk to suppliers, and we need to talk to organizations. Tell them what we want to do. Collect the data. Show them our plan. Tell them how we plan to execute it and where their help is going to be needed. Once we are ready, ask our friends like CCH to help us with expertise. Bring them for a week or two and do the cases with us in our hospital. Only then we will get the ball rolling. Remember, a rolling stone gathers no moss. We must keep moving. And finally, I'd like to acknowledge a few people. First of all, I'd like to acknowledge my hosts. First of all, the Taipei Economic Cultural Office in Papua New Guinea for making the connection. Dr. Nina and her team from the Overseas Medical Mission Center for your flawless execution of this attachment. We really appreciate it. Dr. Mu Kwan Chan, the Superintendent of CCH and his executives, for your warm welcome to your hospital. I felt very welcome. Dr. Xie Changpo and his staff of the Orthopedic Department, CCH, you have been so kind and patient with me. I will treasure the knowledge you have blessed me with. And finally, the government and the people of Taiwan for your kindness and hospitality. To my country, I'd also like to acknowledge Mr. Tommy Kunji and Albert Kopiap of the PNG Trade Office in Taiwan, I felt secure knowing you were within reach. Professor Teforani, Dean of Medical School, UPNG, for acknowledging the importance of this partnership with CCH, and Professor Ikao Kevao, Head of Surgery, University of Papua New Guinea. Your tireless effort in ensuring that this attachment eventuated. Secretary of Department of Health, Dr. Liko, and his chief, the chief surgeon, Dr. Oktipoki, for acknowledging this program. Dr. Molumi, the CEO and management of Port Moresby General Hospital and the surgical division of Port Moresby General Hospital, thank you for your support. Finish?
Very excellent presentation, Dr. Richard. Yeah, and I think for Dr. Richard, this is not the first time to Taiwan. This is the first time, but not the last time. Yeah, I think I hope in the future you can come to CCH again. Yeah, we can arrange like the 1 month very intensive training courses for your more advanced training in the future. For all of the doctors from Moresby General Hospital, when you come to Changhua Christian Hospital, we are most welcome. But not only one times, we wish that you can come back to learn more. Yes, this will be more helpful for all of you. Okay, thank you, Richard, again. So our third speaker is Dr. Chen, the Director of Cardiovascular Surgery Department of Changhua Christian Hospital. Dr. Chen, his topic is coronary artery and very diseases treatment and prevention in Changhua Christian Hospital. Dr. Chen, you also have 20 minutes. The floor is yours, please.
Thank you, ladies and gentlemen online. I'm Dr. Chen. I'm Chief Attending Physician of Department of Cardiovascular Surgery. I know the most common heart disease in Papua New Guinea is rheumatic heart disease and coronary artery disease. So I'm honored to talk about surgical treatment of various heart disease and coronary artery disease in Changhua Christian Hospital. Let me introduce my department in our hospital. We can perform about 400 cases cardiac and major vascular surgery every year. The open heart surgery include adult and congenital case, and also we are an endovascular and LT stent center. We performed the largest number of robotic and minimal invasive cardiac surgery in middle of Taiwan. And we have 24 hours ECMO service in our hospital. We know the open heart surgery is a teamwork. This is our team. We have 7 attending physicians and 2 senior residents and 3 nurse practitioners and 2 surgical technician and 3 extracorporeal technician and 1 case management. This is our ECMO team setting. We have 24 hours emergent ECMO service. We pack required instrument and material in a mobile box so we can perform ECMO service and ECMO surgery everywhere in our hospital. My county, Changhua County, is an agricultural county with many elderly patients. So since 2010, we began to develop minimal invasive cardiac surgery. The conventional open heart surgery, need full sternotomy, is very harmful to the elderly patient. So we developed minimal invasive cardiac surgery for the elderly patient. I think minimal invasive cardiac surgery has a benefit in the following. Is less blood loss, is lower risk of infection, and reduced trauma and the pain, and the shorter time in the hospital stay, and faster recovery, and quickly return to normal activity. Also, smaller and less noticeable scar. So the type of surgery in the following can be performed by minimal invasive cardiac surgery, like LT valve surgery, mitral valve surgery, or tricuspid valve surgery, or CABG, or congenital whole heart surgery like SD, or cardiac tumor like myxoma, or double valve surgery can be performed in our hospital. Since 2014, the proportion of minimal invasive cardiac surgery has been increasing year by year. Like mitral valve surgery, since 2019, the percentage, nearly 100%, use minimal invasive approach to perform the mitral valve surgery. Next, I will talk about LT valve surgery. There are 5 common types of minimal invasive approach for minimal invasive LT valve surgery. I prefer picture B, the right anterior mini thoracotomy. The definition of a minimal invasive LT valve replacement is requiring incision other than full sternotomy and the neat cardiopulmonary bypass. The 2 main techniques of minimal invasive LT valve surgery are mini sternotomy and the right anterior mini thoracotomy. We review the lecture. There are following advantage of minimal invasive LT valve replacement. We can see the post-operative recovery time are significantly shorter in the minimal invasive AVR group, and the mortality and the transfusion requirement are significantly better in the minimal invasive AVR group. There are no difference reported in the incidence of a neurological event between the mitral valve or conventional AVR group. According to this chart, we can see the 5-year mortality rate is better in minimal invasive group than conventional AVR group. So I will show you my setting of right anterior mini thoracotomy for AVR. The surgical incision is made in second intercostal space, and this procedure needed a peripheral cannulation by femoral artery and the femoral vein. I like use the true clamp to close clamp the aorta, and the surgery only need a single lumen intubation. The operation can be performed with only 4 to 5 centimeter wound. This is the video record of the right anterior thoracotomy minimal invasive AVR. We made 4 to 5 centimeter wound. The rhima should be sacrificed. After sacrifice the rhima, the wound protector can improve the vision. And the peripheral cannulation by right femoral artery and femoral vein. This is cardioplegia set. We venting the left heart. This is the true clamp to close clamp the aorta. After close clamp the aorta, the cardioplegia to let the heart stop. Then we open the aorta. We can see the LT valve. This is left coronary artery. This is right coronary artery. Then we dissect, cut down the LT valve. And then we sizing the valve. This is simple method technique for valve replacement. This is another suture technique for valve replacement. We use the Paget. This is the continuous suture technique for valve replacement. Then we tie the valve. And after we close the aorta, the operation is complete. Only 4 to 5 centimeter wound can complete the operation. You can see the scar is very small. Next, we talk about the mitral valve repair. The video assist the mitral valve repair. This is my setting of mitral valve surgery. The wound incision is made at third intercostal space. Also, we need a peripheral cannulation by femoral artery and the femoral vein. And you can see the video set by 4 intercostal space. In the video assist mitral valve surgery, I like to use the flexible, the LT clamp, and we need only single lumen intubation. This is the flexible LT clamp. Only the operation can be performed with only 4 centimeter wound. I will show you the video record of the operation. We can see the posterior mitral valve leaflet porous due to the caudate rupture. You can, and I like to use the neocaudate technique to repair the valve. We put the Gore-Tex suture to the papillary muscle. Then we tie the Gore-Tex to the posterior mitral leaflet, and then we perform the annuloplasty with annuloplasty ring. You can see the competence of the leaflet is not very good. The height is too low of posterior leaflet. So we put another new caudate to pair new caudate at the P2 posterior mitral leaflet. Then we tie the cortex. We use the Starling tester to test the competence of valve. You can see the competence is very good. No regurgitation was fine. I think the repair result is very good. The post-OPT can see no more regurgitation. Next, I will talk about the robotic assisted mitral valve surgery. Since 2014, we start to use the robotic to repair the mitral valve. This is the robotic setting. Compared with robotic surgery to video assisted, robotic surgery has 3D imaging to improve visualization, and the instrument has more degree of freedom. So result of repair is very good, is excellent. Since 2014, we perform more than 18 cases, almost is mitral valve repair. The pathology, 78% is degeneration. I know in Papua New Guinea, is rheumatic heart is more patient, but in Taiwan, degeneration, we have more cases for degeneration disease. This is my repair. I like to use the artificial caudate to repair, and some cases use ring, some cases use band to do the annuloplasty. We'll show you the video record of the surgery. You can see the posterior mitral leaflet porous due to the caudate rupture, and this is the regurgit. You can see we put the new caudate in the anterior papillary muscle. In robotic surgery, you need your assistant to do something. He must need help you to complete the surgery because you are not on the table, you are on the console. Now, my assistant will tie the Gore-Tex, and I put another Gore-Tex neocoated at the posterior papillary muscle. The neocoated technique is very simple, like this, and to repair the bump. Now we use the prosthetic annuloplasty ring to perform annuloplasty. In robotic surgery, you use the continuum technique to suture. Now we use starting test. You can see the competence of valve is very good. Echo show no regurgitation. So I think the robotic assist mitral valve repair, the result is very good. We can see the post-operative echocardiography follow-up is very good. I will talk about the robotic assist CABG in Changhua Christian Hospital. There are three most common minimal invasive CABG. In our hospital, I perform is robotic assist coronary artery bypass. I think the robotic endoscope Lima harvest, the learning curve may need more than 70 cases. After 70 cases, the harvest time may be below 1 hour. I think the learning curve may be near 100 cases. In our hospital, almost patient has more than received more than revascularization number more than 3, 4, or 5. This is the video record. We use the Lima as inflow and connect to the radial artery as the bypass graft. You can see the Lima flow is very good. And we perform the CABG by a mini thoracotomy. Maybe the operation may need 8 to 10 centimeter wound length to complete the surgery. You can see the anastomosis to the LAD. So I think the robotic assist CABG, the result is very good. Only 8% patient need intervention, and no Lima graft occlusion was found in our result. We show you the post-operated coronary angiogram. You can see the Lima to LAD flow is very good, and the anastomosis is very good. This is multiple vessel disease. You can see the Lima to LAD diagonal OM is very good. The flow is very good. The graft is patent. This is 4 vessel disease. You can see the flow is very good, and the graft is patent. So I think robotic surgery in Changhua Christian Hospital is safe and effective. The operative time and the cardio bypass time and the cross-cam time can be shortening through experience, and the major complication is very low. I'm honored to have the opinion to communicate with Port Moresby General Hospital. I hope what Dr. Elizabeth see and learn at our hospital is helpful to her. And I hope he will do well development of cardiovascular surgery in the future. Thank you.
Thank you. Thank you, Dr. Xie. Very professional and excellent talk. And the next, our last speaker is Dr. Elizabeth from Port Moresby General Hospital, and Liz has her training at the cardiovascular surgical department for I think 2 months, I think, and the last 3 weeks, she spent her time at thoracic surgeon department. And today, her topic, we're going to share the future of cardiac surgery at Port Moresby General Hospital. Elizabeth, Dr. Elizabeth, so you also have 20 minutes. The floor is yours, please.
Good morning, everyone, for my colleagues back at home and distinguished guests here. My name is Dr. Alok. I'm a general surgeon and doing cardiothoracic trainee at Port Moresby General Hospital, Papua New Guinea. The topic of my presentation today will be the future of cardiac surgery at Port Moresby General Hospital. Dr. Kulao, Dr. Richard, has already gone through the introduction of where our country is. So I'll just go directly into the presentation. So a brief introduction of cardiac services in Papua New Guinea. So before independence, our independence was in 1975. There was a small cardiothoracic team that was first formed in Leh. But once we gained independence, the specialists from that moved back to their respective countries, and that service was actually dropped. Then from 1975 to 1990, those patients that were diagnosed with cardiac problems and needed cardiac services, those that could afford it would travel down to Australia and seek that service. However, that, of course, wasn't sustainable, and most of them couldn't afford it. So that ended. When that started fading away, there started to be talks by our Papua New Guinean team. A few I've mentioned in the presentation, the late Dr. Kaupa, Professor Kevau, Prof. Vince, and our Australian counterparts that were attached to the Adventist Development and Relief Agency, who came together and discussed about how they could deliver these cardiac operations within the country or to the country. This was more the congenital heart diseases and not to do with adult diseases. So that's when Operation or Open Heart International began within the country. The first operation in 1993 and through to 1995 at Goroko Base Hospital, which is indicated with the blue circle here. And later in 1996 to the present day, we have now moved to the capital city, which is the red arrow, Port Moresby General Hospital. With the affiliation with Open Heart International and our own country, Operation Open Heart PNG, have formed a collaboration. And initially it started off, or most screening processes start off with the pediatrician, pediatric cardiologist, as this is one of our trainees, pediatric cardiologist, Dr. Lita. They travel out to our provinces and screen over 600 plus patients. Once that screening takes place, they, from that 600, come down to about 50 to 60 patients. And from that 50 or 60 patients, we then sit down with the visiting team that comes across and come up with about 40 to 45 patients only out of 600 plus patients, and then decide which patients are to be operated on. That planning process of service delivery has slightly changed over the last 4 years or so. So now it's only to a smaller degree of less than about 20 patients per annum, so twice yearly visits that Open Heart International comes and operates with us. In 2016 and 2017, we had the privilege of having a team from the National Heart Center Singapore that came across to the country and assisted us in doing a few adult open heart cases during that time. The next slide shows pictures of the team. So initially when Open Heart International Australia had started in 1993, there were over 60 plus people that would come in as a team. The team numbers for the last 4 years or so, 8 years or so, but due to COVID, they've dropped down to just over 20 or so team members that come across to help with our local team, the nursing staff and us doctors, to developing our local staff now, which is the trend that the cardiac services in Papua New Guinea are pushing towards, which is local transfer of knowledge and skills and their training. So that is what's happening currently at the moment with our nursing team and the rest of our team and our surgical team, where the local team try to do the cases or are doing the cases while under the supervision of the visiting team. Our local team is comprised of our surgical team. So there's only my supervisor, Dr. Tapawa, and I am his trainee. And we have yet to have a new candidate to join us, Dr. Moimon. And our anesthetic team, we have one cardiac anesthetist, and he has encouraged a new candidate to join him too as well, Dr. Silari. That is the surgical team. For the physicians, the pediatric team, the pioneers of the pediatric cardiology team are Prof. Teferani and Dr. Tovilu. They are now more into the academic side, or administrative and academic push for pediatricians and pediatric cardiology. The team is now taken over by Dr. Kila Lang. Dr. Olita is the trainee, and Dr. Kiramati is yet to join them. For the medical team, there's Prof. Isikeva, who is the pioneer and still practicing cardiologist. We have lost 2 of our cardiologists, and currently have Dr. Boko and Dr. Nem, who are our interventional cardiologists only. They're the only ones in the country, and they're training Dr. Malian. Our cardiac services in the country. The cath lab just began operations in the mid of last year, 2021. So this is basically a few of the statistics that were collected within that time of the services that they provided at the cath lab. So as you can see, the main population are males, or the main admitted to the catheter lab are males. 82%, and within those patients, they are more coronary vessel diseases. Out of the coronary vessel diseases, triple vessel disease is the highest leading cause of admissions to the cath lab at the moment. Going on to my experience at Changhua Christian Hospital. So I had a 3-month attachment here at the hospital. The first 2 months of my attachment were with the cardiovascular team, Dr. Chen in the unit, and 1 month, or this last month, was with the thoracic. The hospital and the technology, as Dr. Chen presented in his prior presentation, it is stuff I read about and I've seen on YouTube, and you read about it, you see it in the textbooks, people talk about it. But now I had the opportunity to experience and watch it and actually be taught by people who do it every day, leaders in this field, which is invaluable. You can never get this in books or just doing it at home or doing it back in PNG. So coming out and traveling out at this point in time in training to experience this, we all have to do it to get exposed to what's happening outside, in the outside world. So the videos Dr. Chen had shared already in detail, but with the coronary artery bypass graphs that I saw, again, most were minimally invasive, and it was just, though the operations and Dr. Chen had mentioned or he talks about it fluently, which I greatly appreciate, and watching it happen. But let's not forget that the skill involved in doing this, it's already difficult enough open, let alone doing it in such a limited amount of space as well. So watching and appreciating this was also invaluable too as well. The valvular heart surgical cases also, all the valves were done, which was again amazing. And using the minimally invasive techniques that were done, there was only, I think, 2 operations that I saw that were open. However, those had their own indications because it wasn't just one valve, it was 2 or 3 valves that needed to be replaced and therefore had to be in an open setting, or the difficulty of the case was seen. So it had to be shifted from minimally invasive to an open case. So appreciating that level of skill, again, doing it in such tight spaces, in such tight room space, is also very important. The patient outcomes that Dr. Chen mentioned, and the quicker the patients got up, the quicker they were out of bed, and their recovery, again, is on the basis also of the skill of the surgeon and actually getting them through the surgery as effortlessly and as smoothly as possible for them to recover so well, which I appreciated. Watching the minimally invasive surgical cases and then going on to watching this robotic cardiac surgery, I appreciated not only the skill and the equipment that needed to be used in actually doing these cases, but also the teammanship in actually getting the job done. So as Dr. Chen had mentioned, he is sitting here and the operation is happening across in the center of the room here, where his assistants are also his extended arms that help him in assisting him in actually getting the job done. But small holes, yet the skill is immense. And watching this actually take place, I greatly appreciate it. Apart from the open heart surgical cases, there were the vascular cases, vascular surgeries that were done, which I watched and observed and also took part in. The AV fistula creations, watching the different skills and different pointers in which they explained how a procedure, the AV fistula, was being done, and seeing the outcomes too as well. Hearing about the management and the management plans preoperatively, postoperatively, and then continuation, following up these patients. If the graft were to fail in any sense, the patients were then brought back in, done angiograms, ballooning, stentings. So they did not just stop at doing the AVFs alone, but also moved on to plan A, plan B, and when it was to fail, what else they could offer these patients to as well, which I found the knowledge invaluable and the skill too as well. Management of peripheral artery diseases and varicose vein management were also some of the few operations that I also witnessed as well during my attachment with the cardiovascular team. A more specialized case was I saw in the hybrid operation, OT. The hybrid operating room is just, it's hard to explain, but the technology in there, and not only technology and equipment, but also skill level and teammanship. Having all those essential people involved in actually coming together to get the job done and to get it done efficiently and effectively for a really good outcome for these patients was beautiful to watch. But having to see it, having to experience it, I will never forget the number of TAVIs and TAVRs that were done and watching this. Apart from in the theater, I had an attachment with the surgical ICU or the cardiac ICU too. Within this time, with this attachment, it is not only cutting the patient or intraoperatively. I enjoyed or appreciated the fact that I did this ICU attachment because of the pre-operative follow-up or look through of the patients that we discussed with Dr. Ho and nurse practitioner Amy, which we would go through every morning. Then we would discuss the intraoperative operation that occurred, and then later discussing the post-operative management. And then we would go and see each patient and see what was happening to the patient, what changes were occurring, why certain things were done a certain way. And all of this, it made the picture more complete in the treatment of these particular patients. And watching the ICU team actually work, because you're as good as your post-operative management as well. Without them to look after your patients post-operatively, there is no good outcome too as well. So their work, again, teammanship, I truly appreciate it. While in ICU, the discussion of and the introduction to me about ECMO, so extracorporeal membrane oxygenation. Again, I have no experience in this at all until coming here and seeing the team, how they used it, how they used to manage these patients too as well post-operatively, and how valuable it is for not only outcome, but actually buying this patient's time to recover from their surgery, or even not only post-operative cardiac patients, but other septic patients or other patients that needed this, this assistance, just to give them time to actually recover. Not only was the ECMO used, but also the essential use of continuous renal replacement therapy. This work hand in hand, as you can see in this picture, where the ECMO machine is the continuous renal replacement therapy machine is attached onto the ECMO machine, and they're working hand in hand to keeping these patients alive. And again, all for good post-operative recovery, and that is where that is what we want to do all in the end. While in theater, I not only disturb the surgeons, but I also talk to the perfusionist, the anesthetist, and the nursing team. The perfusionist, again, though, despite having the language difficulty, we tried our best to communicate, and they were so helpful in teaching me about the cardiopulmonary bypass machine, the types of cardioplegia used, what are the indications, or watching what you needed to watch when weaning a patient off of cardiopulmonary bypass, what things to monitor, how to monitor it, how to treat it too as well. And they were able to go through with me as much as they could on these things as well, and most importantly, myocardial protection too as well, and what the measures they used in terms of assisting the patient or assisting the surgeon in terms of doing the operation or open heart that they needed to do. The anesthetists were able to help me through with Dr. Chen's images that he showed, all the echo findings, the transesophageal echo machine, echocardiogram machine that was done intraoperatively after the patient the heart was closed up, and then observing your what you had done operatively to see if you needed to do a little bit more, to see if what you did was enough. That was also invaluable too as well. So the anesthetic team are the ones that run or at least operate the transesophageal echo to let you know, the surgeon, how you have done as well. The nursing staff were able to assist me in assessing, of identifying unfamiliar consumables, equipments, and tools, and how to use it. What are those important things? So not only skill, but also equipment, which are important to making this a success. So onto the future of cardiac surgery in Port Moresby General Hospital. I divided into vascular surgery and cardiac surgery. For the vascular part of it, the AVFs, which we are already doing, but then now maybe pushing that a little bit more further and talking about angiograms, intraoperative ballooning, and using the CM or the image intensifier, which is also important that we need to use as a tool, because there's only so many vessels we can do AVFs from. Then you got to think of what is your plan A, plan B, and plan C, and that's where angiograms, ballooning, and stenting comes into as well, or even grafts. if that is not an option for these patients, then long-term Hickman catheter insertions are also important too as well, which we have to start looking at. For the cardiac surgery, looking on from coronary artery bypass graft. So here mostly, as mentioned, is more minimally invasive surgery. For us, we're still in the open mid-sternotomy phase, and I think we will stick to that for now. However, I did appreciate the fact of the peripheral access and getting on pump with femoral artery and vein cannulations, and with SVC cannulation too as well for venous drainage. That as a step on going on cardiopulmonary bypass, I thought was is most likely an option for us, or to think about as an option for us. And for this case, for the cabbages, beating heart. But again, it's equipment that are also important, cardiac stabilizers, arterial shunts, blowers, and other things that are also important that will help us in doing this as a beating heart case. Patient screening, patient selection, and again, good perioperative management, starting off with single vessel diseases and then slowly moving on to multi-vessel diseases. For the valvular heart surgery, as Dr. Chen's mentioned, most of our pathology is rheumatic heart disease. So though we will start off as an open mid-sternotomy for either valvuloplasty or valvular replacement in the future, because one, our patients are younger. We start off maybe in the ages of 30s, 40-year-olds that were changing valves. And when we change the valve, because of our poor logistics in terms of monitoring the patients, if we put a metallic valve in or a mechanical valve, we're hard to follow up. So therefore, most of these patients end up with tissue valves that will degenerate over time. So you end up one patient having to change their valve 3 times in their whole lifetime. So you're repeatedly taking them in to do the surgery. So we might actually be looking at pushing onto minimally invasive surgeries for these cases. But again, saying that is one thing, and actually doing it, because the skills needed, the equipment needed will be the biggest difference. So starting off with open mid-sternotomies for these cases, but looking towards minimally invasive surgery at some point. The pictures here of patients from different provinces throughout the country, preoperative patients waiting to come in for screening or at the cardiac screening clinic. So this is at Popondetta, which is the orange circle here. And this is also in Popondetta, post-operative patient that had a PDA ligation done. Our PDA ligations are all open thoracotomies, which we do on our own on a daily, theater-based, weekly basis. And this is our pediatric cardiologist doing a ward-run class, basically echo class for those doctors, HEOs, health extension officers, and nurses that work at different hospitals. And this is taken from Chimbu province, which is here in the red circle. And we are based here in Port Moresby. This is why we do it. So for all these patients, the preoperative patients in line, the post-operative patients in bed, getting them out of bed, exercising, and then sending them home when they are ready. I'd like to thank all these people, Dr. Chen and the team, the ICU team, nurse practitioner, Amy, Dr. Ho, the perfusionist, the anesthetist, and the thoracic team too as well that I spent a week with. And finally, my team back at home, to thank all the representatives from the Taipei Economic and Cultural Office in PNG, the representative of PNG at the Trade Office in Taiwan, CCH, and all the medical missions, and the hospital too as well. Thank you.
Thank you. Thank you, Elizabeth. And also very excellent presentation. So thanks again for all of our speakers. Now we are open for QA for any of our online participants. Before that, I would like to invite Dr. Arnold Weiner from Port Moresby General Hospital. Could you please give us some of feedback? Dr. Arnold, please open your microphone. The microphone is mute now. Turn on your microphone, please.
Wait.
Oh, that's good.
Yep, good.
Thank you.
Can you hear me now? Can you hear me?
Yeah, sure. Perfect. Go ahead.
Very good. Very good. Greetings from Port Moresby General Hospital, and from Papua New Guinea, Port Moresby and Papua New Guinea to you all in Taiwan. Yeah. So I will start. It's quite interesting. Very interesting. I'm very thrilled, especially for me, for my surgical group, team members here at Port Moresby General Hospital. My name is Dr. Arnold Weiner. I'm a general surgeon and an honorary surgeon at the hospital. But my full-time employer is at the University of Papua New Guinea Surgical Department. So I will be second person to Professor Ikau Kevau, who is our head of department and the professor in surgery. It is almost 2 o'clock on our side, and I think most of our fellows are out in the theater or in the wards, and there are some in its rooms where they are tuned into the session or the seminar. Otherwise, Professor Kevau is with us, who is on my left, and then fortunately we have a visitor from another province in Medellin, who also has a attachment before, I think prior, so many years ago, to Taiwan at the same hospital. Yeah, and his name is Dr. John Mahua. He's our head and neck and plastic surgeon. So was fortunate that he came, so we asked him to join us, and he's here with us. Yeah, and then we have our senior surgeons from Dr. Alok's supervisor on the ground here is Dr. Tapawa. He's a cardiothoracic surgeon, and he's been listening through the reports. I think he is really happy. Yeah, and also we have Dr. Kulau's colleague, one of our orthopedic trainee. His name is Dr. Kune. He's now in his second year of his attachment. Okay, so he's been also in the same room. And also we have one of our senior surgeons who's doing his head and neck and plastics. Dr. Myre is also with us. And then we have two surgeons, lady surgeons at the back, right at the back of me. And one of them is the one is doing pediatric surgery, and Dr. Kulau's wife, Dr. Dagam. She's also in training for pediatric surgery. And then we have the other one who is also doing urology. Yeah, so they're at the back of me, right at the back. Otherwise, usually we have a big setup. Normally we come here for our seminars and our tutorials and our practice. These are main surgical tutorial room. Just the one hiccup that happened over the weekend and a few days ago, there was a little bit of hiccup in Port Moresby and at the hospital. So the hospital decided to have a slow day yesterday and today. So most of our workforce will be, did their work in the morning and maybe have taken off to their homes. So otherwise, it is usually busy in this room. With that note, let me just, on a serious note, let me just start with acknowledging the fellows, especially our Taiwan PNG representation to Taiwan, Mr. Konji, who has been really supportive on the first undertaking when we decided to go this direction. There are a few things that we need to iron out, or there are a few things that we wanted to straighten up, and then I think his support and his help was really, really helpful. And there was the thing that we thought there was going to be a big issue he sort of ironed out, Mr. Tommy Kunzi. We acknowledge your support and your help in this site, especially when it comes to international relations and international support from our partners. And our Taiwanese representation to Port Moresby or Papua New Guinea is Ambassador Oliva, I think, is on his holiday in Taiwan, and we wish him the best of his time while he's on holiday. Otherwise, they were very good, helpful, and supportive in our endeavor, especially in the surgical pathway that we wanted to ensure. Council Leo from the Health and Welfare in Taiwan, we also acknowledge your great support in doing the both sides from Taiwan and from Papua New Guinea to make our trainee and our candidates, especially in a foreign land with so many things, so many other things that have happened. But otherwise, from the Welfare and Health Office, Council Leo was very, very helpful. And I think most of our trainees, and especially these two, Dr. Alok and Kulau, as their stay and their time spent in Taiwan, Changhua Hospital is really, really nice. On that really note, also I would like to acknowledge the immediate supervisor at the hospital, Dr. Chen, on Dr. Alok for your support, your help, and inner training. I think, back in Papua New Guinea, we do minimal things. We don't do much of those things that we've just seen, especially in the robotic and minimal access surgery. I think Dr. Alok, as time leads the hospital under the supervision of Dr. Chen, has been really, really important and very nice. So thank you very much, Dr. Chen, and your team in the cardiothoracic or cardiovascular medicine and surgery for very helpful to our candidates, Dr. Alok. And I also want to acknowledge Dr. Isya, the orthopedic surgeon, for his support and mentorship on Dr. Kulau in his training. And we can see from a lot of the things that is displayed and the brief report that we get from our candidates. And we really acknowledge and our big thank you to the two gentlemen for their support. On that note, I would like to really, really acknowledge you, Dr. Nina. I can remember a few weeks back, or 2 or 3 months back, that we were, in fact, trying to figure out how we're going to go about. But I think you did a lot of work, and you make our effort lighter. So we really acknowledge you, Dr. Nina, and your support ever. So thank you very much from our department, surgical department, Port Moresby General Hospital, both Port Moresby General Hospital and the University of Papua New Guinea Surgical Department, to you and your team in Changhua Hospital. The reports from those two, we will, the head of department, Professor Kevao, is here, plus our other colleague surgeons, but we will also relate that information and the report to our Dean of Medical School, Professor Tefurani, about what we do and the relationship, the support that Taiwan Changhua Hospital, Christian Hospital, is doing for our candidates, especially the surgical division. And thank you. We'll relate that to our Dean of Medical School. Some years back, maybe not maybe, but it's 2 or 3 years back, we had a big crisis all over the world in terms of COVID-19. And our trainees and trainee pathways has been closed, especially for the international support, international exposure. And I think as it eases out recently, we didn't know where our trainees were going to go. Usually we have from Australia and New Zealand, and as they said, some from Singapore and 1 or 2 from maybe India. And we didn't know, but I think we're the only department in the hospital and the medical school to break that barrier, to break that yoke, as they say, when everything closes up. Changhua Christian Hospital, Taiwanese government has opened its doors and reached us in this Quemera situation of ours. So that is a very big, though it was a big challenge worldwide, but thank you very much for extending your gratitude to us, your help, and your support to us. And this is, I think, they are the first two from Papua New Guinea coming out into overseas for their training. And that's something that we are proud, very, very proud of. As a background-wise, surgical department is, I would say, is the only department at the hospital and at the University of Papua New Guinea where it trained a big number of surgeons. And our trainees encompasses medical students, which are basically senior medical students from year 4 to year 5. And then we have freshman or resident training program in surgery, where they come in to attend for 4 months, basic surgery. And then we have the trainee registrars. And trainee registrars are 4 years training, where they complete it and then they get their master's in general surgery degree from the university. And after that, as Dr. Kulau said from his preliminaries, that after that we have 2 years of service after your master's or postmasters, and then they do the 4 years higher diploma for their higher specialty in each of those surgical fields. Dr. Kulau is our trainee in Taiwan for orthopedics, and Dr. Alok is our cardiothoracic trainee. Of the same, we have more candidates that are on the pathway for that kind of higher diploma degree and program. We have head and neck trainee and plastics, head and neck and plastics trainees. We have pediatric surgery. We have neurosurgery trainees. We have urology, and then we have cardiothoracics. And we also have, I said the neurosurgery. We also have, we're going to do laparoscopic surgery also. So those are pathways, and we have at least one in each pathway already in their second or 10 years of their pathway. But otherwise, there are about 15 of them right now in 2022 in their specialty program. So we have a big, huge number. And as I said, the surgical department in Papua New Guinea is the only department that embarks into this minor specialty to do training and then become specialty, provide the service out for the 10 million population in our country. So it's quite a big, in terms of workload support, in terms of our trainees, the years they spend, the resources that is are attributed to, and so forth. In terms of the diseases, variety and disease patterns, in surgery, Port Moresby, and maybe for the whole country, we used to deal with trauma as our number one, but then now we are now into infectious disease, surgical management with surgical infectious disease. And then now we are also beginning to see in the top 5 cancer or oncology services. So it's a big number in terms of population and caseloads. So quite often, Port Moresby General Hospital is the only national referral hospital. It is the largest hospital in the country, and where all the referrals are done from the 20 provinces. So it is quite busy in terms of patients, caseloads, and the different pathology and different. So that's the reason why Professor Kevao, as head of the department, so many years ago, had the vision to embark on subspecialty to provide the need for the patient, for the population. So that's where we've driven our objective and our vision towards that services. So that is where we are right now. But otherwise, our
I think that the internet, yeah, have some of the problem on the Dr. Arnold's side. But whatever, we are very appreciative that the Port Moresby General Hospital to support this program and send the doctors to Changhua Christian Hospital for training. So I believe this program will be going to continue, not only for one times. I hope that every year you can suggest the doctors to in different specialty to our hospital for the training, because the Changhua Christian Hospital is a medical center, so we cover over 60 of the specialty training. So any of training in Papua New Guinea General Hospital, if you need it, you can let us know. Then we will arrange, and depends on the doctor's needs, we will arrange the departments for and the training courses for them. And besides that, in the future, when you get back to your hospital for working, if any patient you think that maybe if it's difficult to treatment in your hospital, you can refer to Changhua Christian Hospital. Our team will be take over to care of the patient. I think that the patient referral service, we also can do that. So not only the training, but also like the patient referral service, we also can do that. And I think next year, the pandemic will be going to, I didn't say disappear, but that will be, more stable. So we will start our medical team to Papua New Guinea. Before, actually, every year we send 2 teams to Papua New Guinea, even to go to Nonga or to Ala. So in the future, maybe we can stay some days in your hospital to do like the exchange. We give some of the lecture or topic. So I think maybe next year we can continue to do that. So, and besides that, the equipment donation, we still continue to do that. And this is now affected by the pandemic. So I think next year we have many things to do, and we also welcome more of the doctors from Moresby General Hospital to recommended to Changhua Christian Hospital. Before I closing today's seminar, could I invite the representative Tommy? Would you like to say some words, Tommy, to closing that?
Thank you, Dr. Nena. Thank you to Salok and Dr. Skulau. I think your experiences are very profound and would have a lasting impression on your lives. But as you can see, maybe from your experience, hopefully you can recommend some more doctors, because the opportunities are here. We have gone past the bureaucratic swamps of Waigani, but hopefully we can get around there and then get back, because it's for the love of our country. It's nothing personal. So from your experiences, I hope you can demand for more doctors, and especially at PMGH, where we have the cancer facility to be up and running. We might need a lot of training for our technicians and even people to operate the machines and equipment that are in there. So that's an opportunity that Changhua always has available. And it's not that your training is actually under the MOU that was signed between CCH and UPNG School of Medicine and Health Sciences, but Changhua has been continuously providing training for our nurses and all medical personnel for the last 20 years, and it continues. So that's an opportunity where we can have more of our medical personnel come in for specialist training, especially on equipment, care, anesthetics, nursing. So that has always been there, but for your training, the specialist training, it has started because of the MOU. So we hopefully can have more. Even I think Dr. Weiner is back online. Welcome back online. We lost you. So that's why we are continuing the conversation. But as you said, it's a good opportunity that we have. I mean, if you heard me right, you would have realized my statement that I was saying UPNG, School of Medical Medicine and Health Science, has gone around the Waigene swamp to get things cleared. So there's something there, but UPNG has done well. So I look forward to having more of our doctors, those 15 that are still on training. There's an opportunity here. So as I said, to repeat myself, PNGH has the cancer facility to be open soon. So we can have more doctors on cancer specialty or others, not only on surgery. So that's an opportunity that is there. And thank you, Changhua, for your continued training of our medical personnel for the last 20 years. That's the general training, but on the doctor's training, after Dr. Salok and Dr. Kula, we expect more doctors to come in through. So thank you, Changhua.
Thank you, Tommy, to the feedback. So I think maybe next year we can continue our not only continue our project, we can have more of the doctors. Yeah, maybe 3 or 4 on specialty can come to our hospital for training. So Dr. Arnold, you will support us to recruit the candidate to come to our hospital. Anyway, thank you so much to join us and the surgical team from Port Moresby General Hospital. Thank you so much to join us today. I think this is a very, very encouraged as Dr. Elizabeth and Dr. Richards. So once again, thank you all of our participants online join us. I hope looking forward to see you on next time, and hope that more of doctors to join this program can come to Changhua Christian Hospital in the future. Thank you. Bye. Bye. Thank you.